Prostatectomy. Treatment of prostate cancer. Radical prostatectomy. Radiation therapy. Cryosurgery. Hormonal therapy. Chemotherapy. Other therapy. Treatment choices. Prostatectomy. Radical prostatectomy is the surgical removal of the entire prostate gland and the seminal vesicles. Radical prostatectomy has the best documented survival rate at 15 years after treatment. However, other treatments may have about equal results at 10 years after treatment. Therefore, radical prostatectomy is used for patients with at least a 10-year life expectancy. It is difficult to predict life expectancy. Most men over 70 and men in their 60s with severe heart disease, obesity, or diabetes should probably not be treated with a radical prostatectomy because their life expectancy does not warrant it. There is a quality of life issue that must also be considered. Surgery decreases current quality of life in exchange for a possible increase in quantity of life later when the man is much older. Younger and healthier patients are the best candidates for radical prostatectomy. Methods. Advantages and disadvantages. Complications of radical prostatectomy. Treatment of prostate cancer. Radical prostatectomy. The radical prostatectomy is now done by one of two methods: the retropubic approach, the perennial approach. Retropubic prostatectomy. The retropubic approach starts with an incision 8 to 12 inches long from the navel to the pubic bone. The lymph nodes in the obturator space are first removed. The prostate gland itself is exposed and the urethra is cut just beyond the prostate. The prostate gland is lifted off the rectum. The seminal vesicles are included with the prostate. The prostate is cut away from the bladder and removed. The bladder is then sewn down to the urethra with a rubber catheter passing through the anastomosis. If possible, when peeling the prostate off the rectum, the surgeon leaves behind two small nerves on the edge of the prostate. These nerves supply the penis and aid in increasing blood flow to the penis during erection. If the cancer is close to one or both nerves, the nerves may be cut out also. A rubber drainage tube drains blood and serum from the wound for several days before it is removed. The patient must concentrate on deep breathing exercises, coughing, and walking for the first several days. The patient is able to eat and drink after 1 to 2 days and can go home as soon as he has a bowel movement. Skin stitches or staples are generally removed after 1 week. The Foley catheter is removed in the doctor's office in 2 to 3 weeks. Perennial prostatectomy. Another approach to radical prostatectomy is perennial prostatectomy. Here, the small incision is made under the scrotum. The advantage of perennial prostatectomy is smaller wound and a shorter hospital stay. The disadvantages of perennial prostatectomy are an increased risk of damaging the rectum, the inability to remove the lymph nodes, and impotence. Advantages and disadvantages of prostatectomy. The advantage of radical prostatectomy is that it provides the best proven cure rate for stage B prostate cancer. Radical prostatectomy is clearly superior to any known treatment if one looks at 15-year survival rates. If one looks at only short-term survival of less than 10 years, then radical prostatectomy holds no such advantage. Furthermore, there is an excellent psychological advantage over all other treatments. The patient knows that the cancer is completely removed and that all he has to do is recover from the surgery itself. The psychological relief cannot be discounted. The disadvantages of radical prostatectomy are primarily the risks of urinary incontinence and impotence. These are important quality of life issues, and patients may well be willing to sacrifice some survival advantage or even a few years of old age just to avoid the risk of these complications. In general, the younger and healthier the man, the better the radical prostatectomy is. Bleeding. The average radical prostatectomy requires blood transfusion. There are a large number of veins around the prostate, and visualization of the area is difficult for the surgeon because of the deep location. Impotence. The nerve-sparing radical prostatectomy often allows for functional erections after surgery. By 9 months following surgery, about 75% of men will be able to penetrate for intercourse. The success rate is age-dependent. The best successes are men below age 60. Preservation of functional erections is unusual after age 65. Another determinant of success is the stage of the cancer. If the cancer invades outside the prostate gland, then the surgeon has less success at preserving erections. Urinary incontinence. Most patients undergoing prostatectomy will have some incontinence for a time period. The incontinence usually lasts from a few hours to a few months. The wetting occurs when the patients arise from a chair, cough, or sneeze. Usually they are dry when lying quietly. A few patients are left permanently with a small amount of leakage when straining. Only 1 to 2% are permanently incontinent. Success at maintaining urinary control depends on the surgeon's skill, the stage of the cancer, the patient's ability to exercise his sphincter muscle, the age of the patient, and any neurological disorders the patient may have. Rectal injury. A patient rarely suffers a rectal injury during surgery. The prostate gland lies on the rectum and may be attached to it. Usually this can be repaired, but a patient rarely requires a temporary colostomy for 3 months. Such rare injury is more common with perennial prostatectomy than with retropubic prostatectomy. Follow-up care. Following a radical prostatectomy, the patient is closely followed for at least 5 years. Periodic rectal examinations are done to make sure no local recurrence of a cancer appears at the surgical site. PSA values are obtained about every 4 to 6 months to try to detect any residual cancer. If caught early, some small recurrences can be treated with radiation therapy. If the patient's prostate cancer is pathological stage A or B, follow-up bone scans are usually not necessary. However, if the patient's prostate cancer is pathological stage C or D, then bone scans may be obtained at yearly intervals. Prostate cancer. Causes of prostate cancer. Signs of prostate cancer. How radiation therapy works. How radiation works. Radiation therapy is a form of treatment for localized prostate cancer. The radiation energy used for treatment of cancer is essentially the same as the one used in X-rays, except the intensity is higher. High doses of radiation can kill cancer cells or keep them from growing and dividing. The process of cell kill is a result of serial chemical changes within the cancer cells. Because cancer cells grow and divide more rapidly than normal cells, they are affected the most by radiation. Radiation also affects normal cells, but they recover frequently without any long-term damage. External beam radiation therapy. External beam radiation therapy is a more commonly used form of treatment. Radiation treatment of prostate cancer is delivered by a machine called a linear accelerator. The linear accelerator produces high-energy radiation. It releases electrons, X-rays, or a combination of both that are accelerated to a high velocity. External radiation treatment generally starts with a planning phase, which involves simulation and computer-generated treatment plans. Simulation is a process that involves special X-rays taken of a patient lying in the treatment position. The radiation oncologist determines the treatment fields by examination and by radiological findings. In order to limit the dosage to the normal surrounding tissues and concentrate on cancerous areas, the rectum and bladder are filled with contrast medium during the simulation process. By demonstrating the critical organs, bladder and rectum, with contrast medium on the X-rays, the radiation oncologist determines the size of treatment to be given. The treatment area is outlined with ink lines, which will aid the technologist in directing the radiation precisely at the time of treatment. The treatment planning phase follows a day or two after simulation. The treatment planning phase involves computer calculation based upon CT scan and simulation findings. After treatment planning, the daily treatment begins. The treatment involves high-energy X-rays delivered by the linear accelerator. The patient remains still in the treatment position while being monitored with a camera from outside. The linear accelerator machine may stay fixed or rotate around the patient during the treatment. Each treatment takes only a few minutes. Treatments are repeated daily, 5 days a week, for 7 to 8 weeks, depending on the stage of the tumor. Treatments are painless, and patients often do not experience any side effects during the short treatment period. Complications of external beam radiation therapy. Radiation side effects are usually confined to the area of treatment, with the exception of generalized fatigue and minimal decrease in blood counts. Early side effects that occur during or soon after treatment are generally self-limiting and recover spontaneously. They usually subside in a few weeks after completion of treatments. Early side effects are fatigue and tiredness, diarrhea, rectal soreness, increased frequency of urination, burning sensation with urination. Late side effects are uncommon and occur a few weeks or months later. They are intermittent diarrhea, bleeding from rectum. A small amount of bleeding may occur with bowel movements. The bleeding usually clears with topical medication. Bleeding from the bladder. It is very rare and may require cauterization of blood vessels. Impotence. This effect depends upon coexisting medical, age, and pre-treatment potency status. Small bowel injury due to scarring or perforation is rare. Brachytherapy. One other form of radiation treatment for localized prostate cancer is interstitial irradiation or brachytherapy. Generally, early small prostate cancers are more suitable for this form of radiation treatment. In brachytherapy, radiation is delivered by radioactive sources that are directly placed into the prostate. Depending upon the type of radioactive materials used, placement of sources may be temporary or permanent. Radioactive iodine seeds are commonly used. Radioactive iodine seeds have low energy and long half-life. First, the size of the prostate is determined by an ultrasound. The computer then generates a treatment plan to determine the number of seeds to be used. The ultrasound probe, which is attached to a template with holes, is placed within the rectum. Under the ultrasound guidance, metallic tubes are pushed through the holes of the template. The tubes penetrate the skin above the anus and into the prostate. Once the tubes are in correct position, the radioactive seeds are placed into the prostate through the metallic tubes. The tubes are then removed, leaving the seeds in the prostate. On an average, depending upon the size of the prostate, 60 to 90 seeds are placed. The whole procedure is done under spinal anesthesia. The patient does not need to be admitted to the hospital. Following the implant, the position of the seeds are verified by X-rays and CT scans. After an implant, patients should avoid prolonged close physical contact with pregnant women for the first 2 months. Children should not be allowed to sit on the patient's lap during the first 2 months. Sexual intercourse may be resumed after 2 weeks. A condom should be used. If any seed is lost by urine or ejaculation within 2 weeks of the implant, it should be returned back to the institution wrapped in aluminum foil. Complications of brachytherapy. Immediate complications occur within 24 hours of the procedure. They are usually mild and improve within a few days. They are slight bleeding beneath the scrotum, blood in the urine, bruising and tenderness between the legs. Early complications occur within a few days. They generally subside within a few weeks. Increased frequency of urination, burning sensation with urination, weaker urine flow. Late complications occur a few weeks to a few months after radiation therapy. Scarring of urethra, intermittent blood in the urine, ulceration of the rectum, impotence. Follow-up. An implant is a complicated process. Therefore, it is important that the patient maintains a regular, every 3 months follow-up with both the urologist and radiation oncologist. Cryosurgery. Indications. Methods. Cryosurgery. Cryosurgery is a method for killing a prostate cancer by freezing the entire prostate. A method of freezing the prostate was tried 30 years ago, but the complication rate was too high to continue such treatments. The emergence of transrectal ultrasound has allowed a new method to be developed that appears promising. Cryosurgery is an experimental treatment. There are no long-term survival studies to show whether cryosurgery is effective. The patient for cryosurgery should have a prostate cancer localized to the pelvis. Cryosurgery will not be effective for prostate cancer with positive lymph nodes. All patients should be properly staged to make sure they have stage A, B, or C prostate cancer. The patient should be healthy enough for a spinal or general anesthetic and should have about a 10-year life expectancy. Method of cryosurgery. Cryosurgery freezes the prostate gland using 5 thin probes that are inserted through the perineum into the prostate. The procedure is not particularly painful, but the patient must be absolutely still for the 2-hour procedure. Therefore, a spinal or general anesthetic is used. The patient is positioned on his back with his legs up in stirrups or leg rests. Transrectal ultrasound is used to position the cryosurgery probes and to monitor the freezing of the prostate. The urethra is kept warmed during the procedure to prevent sloughing. The probes are inserted through the bridge of the skin in front of the anus, but beneath the scrotum. Freezing is then done with circulating liquid nitrogen. As the prostate gland freezes, it becomes hard and solid and is easily seen on ultrasound. Care must be taken to avoid freezing the rectum. A small bladder catheter is placed, exiting out to the abdominal wall. This is left in for about 1 week. The patient is usually hospitalized overnight. The patient will probably experience minor bleeding from the probe sites, and bruising of the perineal and scrotal skin may occur. The pain is mild. Post-operatively, the patient can eat. Advantages and disadvantages of cryosurgery. Cryosurgery has some distinct advantages. Cryosurgery is rapid and relatively painless. The procedure does not affect lifestyle much at all. This ability to not affect the lifestyle much makes cryosurgery appealing for older patients. Cryosurgery is the one procedure that can be done as part of a sequence of treatments. Cryosurgery can be done before surgery, brachytherapy, or radiation therapy, and will not make those treatments more difficult or less effective. Cryosurgery can even be repeated. None of the other treatments can be repeated. The disadvantage of cryosurgery is that it is experimental. It will be many years before reliable data on long-term survival is available. It is not yet known that cryosurgery is effective. Complications of cryosurgery. Complications following cryosurgery are divided into those that might occur with any surgical procedure and those specifically unique to cryosurgery. Incontinence. In patients who have never had any other prostate gland treatment, incontinence following cryosurgery is unusual and is mild if it does occur. However, cryosurgery is used as a secondary procedure in patients who have failed a different form of therapy. In those patients who have already had radiation therapy, for example, cryosurgery may be added if the radiation fails to cure the cancer. In these radiation therapy failure patients, cryosurgery does have a rather high incontinence rate. Early studies from the best cryosurgery centers indicate that about 1/3 of these radiation patients have stress incontinence after cryosurgery. Impotence. So far, cryosurgery has been used primarily on older patients. Good data on the effect of cryosurgery on sexual function is not yet available. However, the freezing procedure is not perfectly accurate. Under ultrasound, the urologist cannot see the nerves responsible for erections, and they are extremely close to the prostate. Cryosurgery may cause impotence. No patient should undergo this procedure thinking his future erections will be normal. In addition, there is also often some numbness at the tip of the penis. This could last a few months. Bleeding. Bleeding from wounds with cryosurgery is unusual because the freezing stops any bleeding vessels. However, some patients do have bleeding into their urine. This may require irrigation of the bladder with catheters. Rectourethral fistula. This complication is a hole between the rectum and urethra and results in the mixture of urine and stool. The complication results from freezing too long and too hard, killing the rectal inner surface. Treatment is quite difficult. A temporary colostomy may be required. Surgical repair of the damage may also be necessary. Less than 1% of cryosurgery patients have this serious complication. Urinary retention. Following cryosurgery, most patients cannot reliably urinate for about 1 week. Patients with large prostate glands due to benign prostatic hyperplasia, BPH, or patients with difficulty urinating may not be able to urinate well following the cryosurgery. The prostate gland shrinks in volume after cryosurgery, but it may not be enough. If the patient cannot urinate totally, then a transurethral resection of the prostate, TURP, will need to be performed. This is usually done after 3 months following cryosurgery. Follow-up care. Cryosurgery rarely achieves killing the entire prostate gland. Usually a low level of PSA is left in the bloodstream, indicating a small amount of prostate gland or prostate cancer is still present. Patients having cryosurgery need to be followed by a urologist for the rest of their lives. The digital rectal examination and transrectal ultrasound are no longer helpful in assessing the prostate gland because of the destruction and scarring that occurs following cryosurgery. Therefore, watching the PSA change over time becomes important, and PSAs are obtained at least every 6 months. The best way to assess whether cancer is still present following cryosurgery is to perform needle biopsies. Most urologists perform needle biopsies 3 months after the cryosurgery and then once a year thereafter. Hormonal therapy.